Hello fellas, today let's talk about a very important topic in pulmonary medicine called asthma. This is me, doctor, and I'm here to give you a brief outline about what asthma is and how we diagnose it. What are the different types of asthma, what's the pathophysiology behind it, and how we treat asthma. So let's kick things with introduction to asthma. Asthma, it is defined as chronic inflammatory respiratory disease, which is characterized by reversible airflow obstruction and bronchial hyperresponsiveness. So there are three main characteristics when we're talking about asthma. First is airflow obstruction. Airflow obstruction results due to edema, mucus overproduction, and bronchospasm. Second important characteristic of asthma is reversibility. The episodic airflow obstruction in asthma can be improved with treatment, so it's reversible. And the third characteristic of asthma is bronchial hyperresponsiveness, which is simply heightened sensitivity of airway to triggers. Common symptoms of asthma include wheezing, coughing, shortness of breath, and chest tightness. Let's now discuss how we classify asthma based on triggers. There are two types of asthma. One is extrinsic, which is also called allergic asthma, and by the name itself it says that it's triggered by allergen. Some common asthma triggers include allergens, irritants, and respiratory infections. Allergens are things like pollen, dust mites, and pet dander. These substances can cause an allergic reaction in the airways, leading to asthma symptoms. And another type of asthma based on triggers we have is intrinsic or non-allergic asthma. They can irritate the airways, making it harder to breathe. Next, we have based on inflammation. Based on inflammation. There are two types of asthma. Number one, type 2 inflammation, which is triggered due to activation of Th2 cells, eosinophils and IgE antibodies. And number two is non-type 2 inflammation, which is triggered by neutrophils, and it is less responsive to corticosteroids. And based on severity and treatment, there are intermittent asthma and persistent asthma. As the name suggests, intermittent asthma is asthma with infrequent symptoms, and a SABA, short-acting beta-2 agonist, is required for alleviation of symptoms. Persistent asthma depends on range of severity, and it requires a controller medication. Depending on range of severity, we have subtypes of persistent asthma. They are mild persistent, moderate persistent, and severe persistent. There are other types of asthma as well. Some of them are aspirin-exacerbated respiratory disease, which is due to aspirin or NSAID sensitivity. This aspirin-exacerbated respiratory disease is also known as Samter's triad, which is a triad of symptoms, including asthma, chronic rhinosinusitis, and nasal polyps. This occurs as a result of hypersensitivity to aspirin and other non-steroidal anti-inflammatory drugs that inhibit cyclooxygenase 1. Aspirin-exacerbated respiratory disease typically manifests in adults, often between ages of 20 and 50. The other subtypes of asthma could include occupational asthma, which is due to the workplace triggers. And there is something called exercise-induced bronchoconstriction, which is a type of asthma triggered by strenuous activity. Lastly, there's another type of asthma called cough variant asthma, which has chronic cough as the main symptom. Asthma, a prevalent respiratory condition, presents a complex interplay of genetic, environmental, and immunological factors. Let's delve into the intricate mechanisms underlying its pathophysiology. So, we know that features of asthma are episodic airway obstruction, bronchial hyperresponsiveness, and chronic airway inflammation. It is characterized by reversible airflow limitation, often triggered by stimuli that we have discussed again and again. Excessive narrowing of the airways in response to triggers such as allergens or exercise is what we refer to as airway hyperresponsiveness. Persistent inflammation involving multiple cell types and mediators results in chronic airway inflammation. Airway hyperresponsiveness is a result of smooth muscle contraction, increased sensitivity of airway to contractile agonist, leading to bronchoconstriction. Neural mechanisms, enhanced activity of sensory nerves, and increased release of neurotransmitters contribute to airway narrowing. Structural changes, chronic inflammation can lead to airway remodeling, including thickening of the airway walls and increased mucus production. There are different types of inflammation that could result in asthma. 1. Type 2 inflammation. It is dominated by Th2 cells, eosinophils and mast cells, and is often associated with allergic asthma. Neutrophilic inflammation is involved in severe asthma, which is characterized by increased neutrophil infiltration and release of inflammatory mediators. Endothelial dysfunction. Impaired endothelial function contributes to airway inflammation and hyperresponsiveness. Now let's talk about the cellular and molecular mechanisms. Th2 cells orchestrate the inflammatory response, producing cytokines such as interleukin 4, 5, and 13. Eosinophils release cytotoxic proteins and inflammatory mediators, contributing to airway damage and hyperresponsiveness. Mast cells degranulate in response to allergens or other triggers, releasing histamine and other mediators. Leukotrienes and prostaglandins are potent bronchoconstrictors and pro-inflammatory mediators. Let's talk about the airway remodeling that occurs during asthma. Chronic inflammation leads to thickening of the airway walls, smooth muscle hyperplasia, and increased mucus production. Damage to the airway epithelium can lead to increased mucus production and airway hyperresponsiveness. And there could be neuronal proliferation, which causes increased density of sensory nerves, which can contribute to airway hyperresponsiveness. So how do we diagnose asthma? We first start with the clinical diagnosis. Based on history taking, if we find any history of recurrent wheezing, shortness of breath, chest tightness, and cough, and symptoms worsen in response to triggers like the allergens, exercise, cold air, etc., then it's more likely asthma. While taking medical history, we take note of symptom frequency, severity, timing, as this would allow us to classify asthma and guide the treatment. We should inquire about any family history of asthma or allergies. This helps in understanding if there is a genetic predisposition. Triggers of asthma could be anything like allergens, irritants, infections, exercise, weather, medications, stress. And the person with asthma could have a family history of asthma or allergies. The person could also have other medical conditions like GERD, gastroesophageal reflux disease, rhinosinusitis, anxiety, etc. And if the patient has undergone past treatments, we should assess the effectiveness of the past treatment as well to know what works best for the patient. So moving on to the physical examination. Asthma, which is intermittent, is most revealing during exacerbation. During exacerbation, we could see something like signs of respiratory distress, like rapid breathing, use of accessory muscles, cyanosis. On lung auscultation, we could hear wheezing and decreased breath sounds. We could go for some objective tests or investigations, and the number one choice for us is pulmonary function tests. We use spirometry for looking at the airflow limitation, since this is an obstructive disease of the airway. So what are the different things we see in PFT? Forced expiratory volume in 1 second, forced vital capacity and their ratio. We could do bronchodilator reversibility testing, which differentiates it from COPD. We could do something called bronchoprovocation testing, which we achieve by using methacholine. It's called methacholine challenge test for airway hyperresponsiveness. We could do peak expiratory flow monitoring, which tracks lung function over time. Other tests include allergy testing, blood eosinophil count, and FeNO measurement. We could rule out other conditions by just looking at the radiograph images like chest X-ray and CT scans. We could run sputum analysis to know what exact inflammatory cell types are present there in the sputum. In this video, we talked about what asthma is, the different types of asthma, pathophysiology of asthma, and how we diagnose asthma. In the next video, we will be talking about the treatment of asthma.